Can you see the slides?
Yes, perfect.
I put in presentation mode. Sorry for being late. Obviously, when you do not travel to the meeting, anything may happen in your place, and and we had an embolizer device to retrieve. So disclosures. I've not. I reached a little bit late your presentation, but just a kind of outline of the presentation. We will be having a chat around muscular VSDs, residual post VSDs, kind of perimembranous and post myocardial infarction. This is the diagram of the position of the VSDs within the septum, interventricular septum, and it is possible to check under echo guidance where these VSDs are located. In particular for muscular, but also for all the types of VSD, we would like to have all needed information in order to plan our procedure and to make the choice for the ideal device to perform the procedure. So the size, number, location, associated defects, or eventual contraindications to percutaneous closure. So these apply to muscular, but also to other types of VSDs. And we usually try to integrate data from echo with data from fluoroscopy, EKG, and also I like to sometimes balloon interrogate or balloon size or balloon check these VSDs, and we will see some of those cases. The margins, the size, in particular for muscular, usually we're seen on 2D color. And let's come to the devices available and which may use to close the VSDs. The muscular VSD device from Abbott is the first one which has been developed. Then there are similar devices from Cocoon and from Occlutech, which has similar concepts, but I'm more expensive with the muscular from Abbott, and then the corner device that you can see on the left side, which is nowadays the device I'm using the most. And sometimes also the plug 2 device, which is a vascular device, can be useful, and I will show you an interesting case. There are also reports about the use of duct occluders and coils to close from PFM to close the VSDs, but no experience in using PFM coils for VSD closure. In particular, the corner device has an interesting shape and concept. It has two screw mechanisms, one on one disc and one on the other disc. So it is possible to screw your guide wire from one of the two sides, and this is possible to then decide which direction to implant. There is a distal lead disc named left disc here, which is connected to the central waist, which has a cone appearance, and then a right disc, or the other disc, let's say, which is connected with a central pivotal segment. So it is possible this device can adapt quite nicely to different anatomies and different approaches. Not all the sizes has a membrane inside. In fact, the smaller sizes, as you can see here, has no membrane inside. Then they can be implanted to a 4 or 5 French sheet, while the larger sizes have a membrane inside, and then they can be in. They need larger sheets. And as you can see, 18, 12, and 14 is the, let's say, maximum size of the defect that can be closed with this device. Let's see several cases. This is a mid-muscular VSD device, which has been approached. This is a mid-muscular, but we shall see some of those cases. But here we have a high muscular VSD device, VSD defect, as you can see in this steel frame, and it is possible, and it is my preferred option with both muscular VSD from Unplatzer and Konar to go retrograde. In this way, it is possible, in fact, to place the long sheet into the apex of the right ventricle, and eventually, when coming back with the distal disc open, it's possible to check if there is any interference with the tricuspid valve. And it is easier, we shall see several cases, to check for interference with the aortic valve. And if this happens, it is easier to just pull back the proximal disc and reshape it or push under the valve. In this case, the left ventricular disc is clearly under the aortic valve, and at release there is a nice position of the disc over the in the right spot. And it is eventually possible to try to manipulate the device in order to place it in the intended position. Another retrograde. Again, here we can see how we usually prefer to put the long sheet into the apex of the right ventricle, and at this stage, the interference with the tricuspid valve can be ruled out. A body wire can be left in place in order to check to have the possibility to advance again eventually the system. And you can see that it is possible also to perform test injections from the long sheet to properly analyze the local situation and the eventual interference of the valves with the discs with the tricuspid valve or aortic valve, and be sure that the device is across the interventricular septum. This is the release phase. The device is really close to the aortic valve, but not interfering with the aortic valve. And a nice final angel. This is another case. Again, here what I usually do is to perform small injections from the long sheet, and you see that we are injecting the right ventricles, and we clearly see where the right ventricular aspect of the VSD is. And I'm more sure that I'm placing the device in the right spot. You see this is a Konar device, and again for high muscular, but also kind of mid muscular, high muscular, the defect. My preferred approach is from a retrograde approach. As we have seen, it is possible to implant close the defect up to kind of 8 millimeters by using a 5 French sheet, while when it is needed to have a larger device, then you can manage to perform the procedure with a 7 French sheet, which is doable even through a transaortic approach in patients weighing 10-15 kilos. Obviously, it is needed to check the artery before. Another interesting case with a Konar device, high muscular, or kind of perimembranous with a small rim, because with this device is also possible to be used in perimembranous VSDs, but a small rim, at least 2.5 millimeters, is needed. You see how it is soft, and there is kind of pivotal mechanism that allow the device to adapt to the anatomy, and the two discs are not forced to be parallel as it happens for the Abbott device. So again, a local check with the injection from the long sheet and the final appearance of the device, and you see that the two discs are not perfectly parallel because the device adapts nicely to the anatomy. And this is the final angio into the ascending aorta with no aortic regurg, even if the device is really close. Sometimes we end up in treating multiple defects, as in this case was stuck under artificial ventilation even after PA bending, was asked to us to perform double VSD closure, or in that other patient who had a story of bending, multiple VSDs, and surgeons asked us to try to close as much as VSD as possible before trying to bend. So what I do like to do, I mean, in these cases where it is really difficult to understand where actually how many defects are there, and it is not always easy. So I do like to perform sizing, which gives me also an idea of the consistency of the rims and the size of the device that I would then end up using. You see, we have a balloon in kind of a high muscular VSD and a balloon in a mid muscular VSD with a nice waist, 5-6 millimeters each. Then the two balloons inflate at the same time, and an injection showing me that, I mean, the residual shunt is quite smallish, let's say, as you may see here, at least compared to before. So we were quite convinced to go ahead and implanted the first device more on the mid-muscular, in the mid-muscular position, coming from below, because the jugular artery was occupied with the other defect. We didn't want to lose the position. So first device implanted in a mid-muscular position. You see the left ventricular disc open, and then and here you see again the device put closer to the septum, and then the opening of the right ventricular disc. The next step was then to approach the other defect, balloon sizing again with the injection, because that stage there was also the possibility, I mean, for the surgeon to perform, closure of this high muscular VSD, but finally we convinced him to perform closure of the high muscular too, coming in a retrograde way, as you can see here. And again, I'd like to go retrograde in this defect, because then it is possible to check for an interference of the right ventricular disc with the tricuspid valve, and properly control the opening of the proximal disc. You see here we are opening the proximal disc, which is going to end up into the left ventricle. And we shall see that it is going to have a weird appearance. As you can see here, there's a long distance between the two discs, and I mean, was anticipated that the device was impinging into the leaflet of the aorta. But at this stage, it's quite easy, I mean, to just pull back the proximal disc to re-advance the long sheet, and to implant the proximal disc by pushing, trying to avoid the aortic valve. And you see now the appearance of the right ventricular of the left ventricular disc is much better, with a nice look. And this was confirmed by angio. There is quite a aortic regurg, but it is now related to the delivery sheet and to the delivery cable, and not to the interference of the proximal disc. Finally, this was released. There is still some residual shunting, but it is clearly through the disc of the devices, plus probably some small other defects. and no interference with the aortic valve, nice appearance of the two devices. And then the surgeon performed, in this case, plasty of the right of the pulmonary artery. Here you see a final angio. There is still some flow across. As Mark said, we would like to have a quick closure, but sometimes it does not happen, and some of those patients may experience hemolysis for a while. And this is another similar case, but in this case we did perform closure of two VSDs, more kind of central. And again, balloon sizing it's something I like to do to understand a little bit better about even also where it's going to be kind of the landing zone. And that patient, in that patient, we did perform also ballooning of the pulmonary bending. We have started this way of dealing with these patients, and most of those bendings may be dilated with okay, this is the final angio, quite residual shunting through the devices. You see there is a corner and the Abbott device, and the bending is now released by after ballooning. As a problems, also Mark reported some of those problems. The device may get entangled in the tricuspid valve, but I think this is mostly may mostly occur when having an anterograde approach, and eventually the risk of entanglement of the tricuspid valve with the disc is less when having a retrograde approach. Quite interesting case is this 1 year old, 9 kilo with failure to retrieve and VSD mitral regurg. As you can see here, there is quite a significant VSD, left ventricular overload. And in this case, I used the plug 2 device. You see there is a cord of the tricuspid valve really close to the VSD. And probably this can be also seen in this picture. I mean, the tricuspid valve is really under, the VSD is really under the tricuspid valve. So in those cases, I think it's really useful to use a plug 2 device and a special tip technique. In fact, we were passing always through the cord of the tricuspid valve, and when trying to implant even the plug 2, there was quite significant tricuspid regurg. So at that time, we left the guide wire even through the cord, advanced the kind of Berman catheter, or balloon tipped catheter over the wire just at the entry of the ventricular, the VSD. And then, so you see here, and then we inflated the balloon and advanced from the mouth of the VSD with the balloon inflated towards the apex of the left ventricle. So finally, we ended up in being able to avoid the tricuspid cord, even if there is a harm getting into the field. You may see that there is some tension on the right side of the screen with the catheter, and then the catheter passing through towards the apex of the left ventricle, of the right ventricle, sorry. So again, the balloon over the wire was anyway passing through the cord, and the balloon inflated is, and then again with the balloon inflated, it was possible also to show clearly that the guide wire was passing through the cord, because when we retracted the balloon, we were having a tricuspid regurg. Having tried to avoid the tricuspid cord, we were then able to advance a long sheet, and then this plug 2 device. As you can see, the device was, there was quite a long distance between the two discs. Okay, let's see. And this is the position of the device into the heart, with I mean, trivial tricuspid regurg and closure of the VSD. Oh, sorry. Oh, sorry. And this is the final appearance with the device following kind of the anatomy, let's say, respecting the tricuspid valve and closing the VSD. So it's a very nice device in challenging situations and in small kids. And it is something that can be used. In particular, there is a paper from Alan Fraise who described the use of this device. Some few slides, if I'm not too late for you, about residual post-surgical VSD. I heard that Mark told already about this special subset of patients where it is really difficult to understand where the defect or the defects are and what is the size. I do like again to help myself with balloons, so that gives me also the waist where I think it will be the landing zone for the device. In this case, it's 10 millimeter defect, and again, by using a retrograde approach, we perform the closure by using an over-the-wire technique. That means that the device is passed through sorry, come back to the previous slide. Guide wire passes through the mesh of the device and the central waist, so kind of over the wire device implant, and this allows us eventually to regain, I mean, the right ventricle if we are not in the right spot. And eventually, it is also possible to release the device from the delivery cable by having this safety net available. As you can see here, I mean, the device is over the wire. This is a Terumo wire, so very soft, and eventually, if it moves or embolizes, I mean, it will be probably easier to retrieve the device. It happened to me just once in a post-myocardial infarction VSD, and it was quite useful. Yeah, sometimes even after having put one or two devices, as in this case, you can see on the right side of the screen was perfectly closed. This patient developed now a third residual VSD, and finally was operated on with surgery. Some tips and tricks, but the most important thing for me is to use balloon to check the position of the defect and have a better understanding of the size. Perimembranous, truly perimembranous VSDs are nowadays, I mean, not plausible anymore because of, I mean, we do not have what was a very nice device that Mark showed already, but the problem was the occurrence of complete heavy block in a significant amount of patients. But it is still possible to close perimembranous VSD with a septal aneurysm in a quite safe way, with the older device or with a muscular VSD or corner. In this case, these are the older perimembranous VSD device with a nice position within the aneurysm. And finally, just a few words about post-myocardial, which is very challenging population, high mortality, and the anatomy is much different. It's not a hole, it's just kind of tunnel within the diseased and dead tissue. And the substrate is really a kind of ventricular septal rupture rather than a congenital fall, for sure. CT MRI can give us some details about the anatomy and the course of the defect, and eventually we aim to close the not simply this patient had some pericardial effusion, but just move forward. We can aim to close the not simply the defect, but the mouth of the aneurysm, because usually there is also an aneurysm that is created by the impacted tissue, So we may have to close the distal hole rather than the hole on the interventricular septum. So this is a muscular VSD. You may see, the device is clearly in the right ventricle because we are, while the VSD is more here, because we are closing the mouth of the aneurysm rather than the true VSD. But what is important that it works and that the patient may recover well if the procedure is successful. Yeah, so you see again, this is another case with a quite nice aneurysm, and the same. Sorry, we have the same patient. So, and this is the CT control CT. You see where the device sits clearly within the right ventricle, but and this is the left ventricle, and there is quite a complex rupture of the septum. But finally, what is important to close the defect and relieve the hemodynamic burden. So thank you for your attention.
Thank you, John. So,
yeah, I can hear you, not perfectly well, but I can hear you.
Are there any questions from the floor?
What diameters do you use for sizing? How do you size the right device? Which size do you use and what parameters do you base that decision on?
Okay, the question from the floor is, how do you decide which size of device to put into the patient?
I cannot hear perfectly well, but the question is what size of device after sizing, or what type of balloon for sizing?
No, the device, the size of the device. How do you decide which size of device to put in?
If I'm convinced with the echo pictures, which is, most of the cases for congenital VSDs, which are not multiple VSDs, for example, I do take 1 or 2 millimeters more the size given by echo, both 2D and 3D echo. If there are nice pictures. When it is not clear, as in post-surgical VSDs or in multiple VSDs, as you have seen, it was really impossible to really understand. I do use balloons, and I do take waist. I do try to obtain waist, and then I use the size of the waist in order to perform sizing or checking or interrogating the septum. I do use angioplasty balloon, peripheral angioplasty balloon, or tie shock 2 ZMED balloons. Obviously, I do not go for high pressures or pressures. I just do and inflate, and I do not gently and inflate. So we do not get more than 1 atmosphere, let's say, by gentle hand inflation, and I do take the size of the waist I can get.
But that's not the patient where you have a perimembranous VSD and you measure the opening at the left side, it will be 8 millimeters. And then you have a big aneurysm. The final opening towards the right ventricle will only be 3 millimeters. What device and it's big aneurysm? Most likely you will be able to put the device completely within the aneurysm. So what measurement to take over there?
Yeah, if I've got in the right way, I would put the device at the mouth of the aneurysm, so more into the right ventricle, because we do fear, to be in touch with the interventricular septum for the risk of complete heavy block. And so, this the device to be chosen would be the size of the opening of the mouth of the exit point of the aneurysm, and both muscular VSD or a conar device. Right now I'm going more for a conar device, which is softer than the muscular VSD. device. It is important, obviously, to be sure that we are not interfering with the tricuspid valve, because then the aneurysm is tricuspid tissue in some way. So we want to avoid tricuspid regurg, and that's why I don't know what is your approach, Mark, but personally, I would prefer to go retrograde.
I mean, I think that indeed the corner device has changed the field enormously. The corner device made it possible to work great, soft, and that's really good results. So, I think in our practice nowadays, we would close 90% of VSDs with a corner device. Is that also your experience? Did you hear the question, Gianfranco?
I've lost the last part. You close 90% of your defects from?
With a corner device. The perimeters, I mean, they are really a game changer because of software. It has less AV block. You can open it from either side.
Yeah.
Two screws on each side. I mean, it was a game changer, for us.
Yeah, that's also my practice too. But what I may say that we still need with this device a teeny tiny, rim. While with the older perimembranous device, you could have had 0.5 millimeters. So we were closing also perimembranous VSDs with no aortic rim or virtually. While here you need some, a small amount of tissue. But again, I agree. It's my practice too to close perimembranous VSDs with a corner device with very good success and very good results.
Any other questions from the floor? Yes.
Is there any parameter, pre-operative or risk factors for heart block?
Yeah.
Is there any parameter we can do it with pre-operative new device or risk factor for heart block?
So the question is, can you assess pre-procedure which patient is more likely to have an AV block with your device, and will it influence the choice of your device?
Yeah, there are some risk factors which are Down syndrome and younger age. With the Abbott device, it was shown that patients aged less than 6 years were at much higher risk for AV block. And again, there is no way to avoid. Actually, just you need to implant and see how it goes. But at the moment of informed consent with parents, this should be put clear that this risk is still there, even if less than before. But I would be a little bit more afraid of down patients, young patients, and the VSDs with kind of inlet extension also are at a higher risk of AV block. But then either you ask your surgeon to perform the surgery or just take the risk and see how it goes. But since the new devices are available, Connor, I have not had any complete AV block yet, so we are quite optimistic.
I would confirm that it's the same for the surgeon. So the perimembranous VSD inlet extension has a higher risk for the simple reason that his bundle is running on the edge of the VSD for a much longer time. Instead of for a few millimeters, it can be quite a few millimeters. And the longer it goes on the edge, the more risk you will have to get the block. But also for the surgeon. Most surgeons will be able to close it. They also, the big difference between a surgical closure and a device closure is that the surgeon will put his patch on the RV side. He should stay away from the hip bundle. And if he touches anything from the conduction system, it will be the right bundle branch, but not the left bundle and not left anterior. Yeah. So that's why frequently after big VSD, you have a right bundle branch, because that suture the right bundle branch. The devices, because we have a disc on the left side, and then we still have the core of the device, and that may push on the his bundle and the trifurcation of the electricity. So the risk is slightly higher. Any other questions? Otherwise, we will take a break and go for coffee. I think you answered all the questions, Gianfranco. Thank you very much.
Thank
Have
you.
a nice day. Have a nice day in Rome.
Thank you. Thank you.
Your slide is suggesting it was very nice of you.
Thanks a lot for having me. Thanks for your patience, and hopefully be able to join next year. Really willing to. Have a nice day. Bye bye.